Um, Good morning, everyone. My name is Khalifa. I'm one of the second-year cardiology fellow at Children's Colorado. So today we'll be talking about Fontan completion in two of our patients with single ventricle physiology and PCD. So as we all know, PCD is a rare genetic disorder that's characterized by impaired ciliary function and chronic respiratory symptoms. And Fontan is considered the final stage in single ventricle physiology, and it's dependent on the passive pulmonary blood flow. And there is quite challenges with the impaired ciliary function, and that leads to compromising of this Fontan circulation. There is a quite significant knowledge gap in terms of the outcomes studying Fontan in patients with BCD. So I'll touch briefly on the three stages of single ventricle palliation. Stage one is establishing systemic or pulmonary source of blood flow, and followed by stage two, where we have the connection of the SVC to the branch pulmonary arteries, and which is between 3 to 6 months, and between 2 to 4 years is the Fontan circulation, which is complete connection of the IVC to the branch PAs. And in this state, there is a total, the venous return is totally passive, so any increase in resistance in the lung usually affect the blood flow or the Fontan circulation. So the objective today, we'll talk about the clinical course of these two patients with congenital heart disease and BCD who successfully completed Fontan. The first patient is now a 3-year-old female with atrial situs inversus, discordant AV connection with mitral atresia and hypoplastic left heart, and double outlet right ventricle with pulmonary atresia. The palliation stages included PDA stent at the age of 7 days, followed by a Glenn at 7 months, then stage 3 with a Fontan at the age of 3 years. The BCD diagnosis was done through genetic testing within the first week of life. Then and the hospital course for this patient included 11 days of total of hospital length, and 3 days of this was in the ICU, and 8 days was in the step-down unit. And they were like on a scheduled respiratory regimen with levoalbuterol, hypertonic, and chest CPT with easy BAB every 4 hours, and that kind of tapered towards the end of the admission. The follow-up now, 2 months after the Fontan completion, and the patient had 1 hospitalization for pneumonia. The second patient is 11-year-old with heterotaxy, right isomerism with unbalanced AVSD, and double outlet right ventricle with pulmonary atresia and obstructed TAPVR. The palliation stage 1 was with BTT shunt at 3 days, followed by a Glenn at 8 months, then Fontan at 2 years. And the BCD diagnosis was a little bit delayed before Glenn at the age of 3 months, which was done was confirmed by electron microscopy and genetic testing. The hospital course initially, there was elevated Fontan pressure with a low cardiac output shortly after the surgery, requiring the patient going to the OR within day 2 of surgery for revision. Then the total length of hospital stay was 18 days with a CIC of 6 days and 12 days of step-down unit, and also were in scheduled respiratory treatment throughout this day. And now this patient is 9 years after the Fontan completion with total of 5 hospitalization due to respiratory infection. This table just briefly describing the pulmonary vascular resistance for these two patients. So for the first patient, initially in the pre-Glenn cath, had pulmonary vascular resistance of 4.6, which considered elevated, required initiation of sildenafil, and a repeated cath after 3 months showed that the pulmonary vascular resistance went down to 2.7, and then the pre-Fontan cath was also elevated at 3.3, requiring initiation of second agent of pulmonary vasodilator. And in the patient number 2, also had elevation of pulmonary vascular resistance at the first cath for pre-Glen, which improved after starting sildenafil, and it was normal at the time of Fontan. So in discussion, patient with BCD are at increased risk of prolonged hospitalization, pulmonary hypertension, and respiratory infections. Both of our patients had minimal respiratory morbidity and slightly longer length of hospital stay. And both patients had delayed stage 2 due to elevated pulmonary vascular resistance that improved after initiation of pulmonary vasodilator. Clinical implication, Fontan is feasible in patient with BCD. Early diagnosis of BCD, as well as proactive respiratory management and multidisciplinary coordination are essential to minimize the morbidity and the length of hospital stay. There is still a knowledge gap in terms of identifying the long-term outcomes of Fontan in patient with BCD. So we have ongoing project with SV1 to understand their pre-operative risk factors as well as the long-term outcomes. But still, there is a limited number, I think, related to being underdiagnosed. We believe there is a great need for collaborative projects to help understand the long-term outcomes of Fontan in patients with BCD. Thank you.